So perhaps we should restart again. So welcome to the data science talks. Today we have Eric Ryszkiewicz with Palo Medical Foundation in California. So he's the predictive analytics and data science lead for the foundation's division of clinical business analytics. So I think I read about your CV, so he really has a very rich professional experience. So he has worked on many different things, including sales, communication process development, air quality monitoring, and also like quality management in solid organ transplantation. And today he's going to share his experience, first-hand experience of working on clinical business data. That's what I imagine, and also talk about data science applications in healthcare. So without further ado, please join me in welcoming Eric.
Thank you very much. Thank you. Yeah, go for it.
Please go ahead.
Okay. Thank you for coming out today. So I'm an analyst in the Division of Clinical Business Analytics at a nonprofit medical foundation. My department generally focuses on the stand-up of automated reporting for large numbers of users or ad hoc requests that are of value to organizational stakeholders. Basically, I work for a large medical healthcare organization, and when they want reports, we build them for them. I don't know a whole lot about what everyone's training is like. I would imagine you all come from rather diverse undergraduate backgrounds if you're in graduate school. But I do assume that most students here will be well prepared to tackle some of the trickier problems we get, including ones that are like what I'll describe for you today. I do not consider myself to be a good programmer, but it is what I pretty much do every day, all day long. If I've been successful at all, I think it's because I try to use my imagination, and I'm very pragmatic, and I've had some advisors and managers and mentors who aided me in the development of these qualities. I'm going to talk a little bit about some background information, what the environment is like in the United States for healthcare, tell you what Palo Alto Medical Foundation, or PAMP, is, and describe to you the sort of important aspects of our electronic health record. And then I'm going to talk about at least 4 initiatives, 3 of which we have at PAMP, and 1 from some previous work that I had done. So we have a bunch of initiatives that focus on things like how well different surgeons perform. That's our outcome information program. And we have a 30-day readmissions estimate for hospitalists. Their particular medical specialty, 30-day readmissions is a pretty good metric that lets them know how they're doing. As well as access in primary care. When patients need to see a doctor, we can measure the extent that that's possible, and that's sort of what we talk about when we talk about access. So we try and perform some forecasting that helps departments manage that. And then finally, I'll talk about some organ transplant work that I had done when I lived in St. Louis, Missouri. For those of you that are maybe meeting with me after, or if I, by some magic, finish early, I'll also talk about some forecasting that we're working on for specialty access. This would be trying to forecast the need to see new patients for dermatologists or gastroenterologists or plastic surgeons and things like that. So currently, we're in a fee-for-service environment in the United States. When patients receive care, those services are paid for by insurers or patients directly. We could have a system where providers were reimbursed based on how well they managed an entire patient population, but that's contingent on the ability to evaluate and price quality of care instead of volume. In 2009, Congress passed something called the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act, as part of the federal stimulus package. It contained provisions for the Department of Health and Human Services to basically dump $30 billion into the United States economy to promote the use of electronic health records and achieve significant improvements in care at the population level. This was a big step towards a system in which outcomes can be determined on a very large scale. It seems inevitable we'll eventually transition to a model where organizations such as mine will be paid based on how well we're able to care for patients, instead of how many visits we had or lab tests or MRIs we ran. Palo Alto Medical Foundation, or PAMP, is a network of over 1,300 physicians operating out of offices that cover much of the San Francisco Bay Area, from South San Francisco down the peninsula to San Jose and Santa Cruz, and you see even a couple locations over there in the East Bay. It has a staff of about 5,000 and hundreds of thousands of patients, and we experience about 2.5 million office visits per year. We're also an affiliate of Sutter Health, which is a much larger healthcare network that covers clinics and hospitals for much of Northern California. PAMP itself doesn't own or operate any hospitals. As an analyst for PAMP, I have access to the reporting database for our organization-wide electronic health record. This database contains information for all contacts between Sutter Health and 10 million patients. I generally support PAMP, but I have the ability to tap into a much larger data set if I need to. Finally, with the sort of intro stuff, the electronic health record we use is known as Epic, and they're the biggest player in that market. To say that we run on Epic is similar to saying, like, my office uses Microsoft. They have a suite of related products that are centered around an essential core platform. The production environment that offices and hospitals use for chart review and data entry of all forms runs on the Epic Chronicles database in real time. Unfortunately, because we have 10 million patients, I don't know how many thousands of visits going on at any given time, this Chronicles database is not a relational database that, as an analyst, you would want to use. It is designed to support pulling up pretty much someone's entire medical history very rapidly, but a single patient at a time for large numbers of simultaneous users. So every day there's an ETL process that makes data available for reporting sometime between 5 and 7 a.m. The data that I have access to in the Clarity data warehouse is up to date of the prior midnight. So Clarity is a reformat of most of the information that's in Chronicles. And that's something that you can query using SQL and whatever your chosen application is. I use SQL Server Management Studio, but it doesn't matter. So I'm going to spend some time talking about PAMP's Outcome Information Program. If you needed to have a major medical procedure such as a knee replacement, you might like to know if your orthopedist was a good surgeon, or at least that he knew whether or not he was a good surgeon. PAMP's Outcome Information Program is designed to allow individual surgeons to see how they stack up against their peers, and for us to get some sense of aggregate performance in a number of surgical specialties. Sutter doesn't have many hospitals in the area that PAMP serves, so our proceduralists have privileges at a number of local institutions. And those are outside of Sutter Health. I have access in Clarity to billing data about surgeries in the inpatient setting, but the other information about what happens during those hospital stays doesn't necessarily flow into our EHR. As an analyst, if I can't tell whether a patient had a blood clot or a post-surgical infection, I can't have any objective measure of whether their surgeon or care team was any good. To address this problem, we've brokered data sharing agreements with 6 partnering hospitals to make at least some of that information available for our use. This has been the most challenging aspect of this work. The analytics are actually not really a big deal. Participation is voluntary. No money exchanges hands. And PAMP had to consider how we'd get the maximum amount of cooperation while asking the hospitals to do very little. Our approach thus far has been to leverage some existing medical information reporting for California that's mandated by the Office of Statewide Health Planning and Development, or OSHPD. On an annual basis, hospitals are required to submit de-identified data to OSHPD. 1 record for each hospital stay, with information about dates of admission and discharge, and diagnoses and procedures in ICD-10 format. It's the International Classification of Diseases, version 10. It's just a code set. Twice a year, hospitals prepare a similar data set for us, but supplement it with some identifying information about patients and PAMP providers that were involved in any procedures. The analytic burden on the hospital is low. They have to be able to give this report. They have to be able to generate the core elements of this report already. We're just asking them to put some extra information into it. We've still had to be inventive about how we identify patients and how we define procedures. Hospitals submit data in a secure manner, so this is just a portion of the diagram showing, secure transport across our firewall and how it comes to us. And it's stored in a dedicated OIP database. That's short for the Outcome Information Program. The submitted procedures are in ICD-10, but our providers think of surgeries in terms of CPT codes, or common procedural terminology. That's a code set that's owned and managed by the American Medical Association. For a given procedure, there can be a confusing web of many-to-many associations between the two. Our Clarity database has the billing records, though, with CPT codes, dates of service, and other information that allows us to join them to the hospital data. Some procedures require a cancer diagnosis in the hospital record as part of their definition, which has made estimates of the volumes of those procedures difficult before we receive the data from the hospital. Otherwise, we know the volume of the procedures. We just need the hospital data for the outcomes. We've defined 1 or 2 Sentinel procedures for a bunch of surgical specialties. And some of them are listed here on the left. So for orthopedists, that's the total hip replacement and total knee replacement. For general surgeons, that's mastectomy. All of these surgeries are generally associated with 1 or maybe 2 specialties. Within some of those nominal procedures, we've broken them down into sub-procedures based on knowledge of differential risk among our physicians or evident from the literature. We've got 13 different flavors of hysterectomy. And that's based on route of entry, whether the procedure was laparoscopic or maybe robot-assisted. On the right are the statistics and post-surgical outcomes that we track. I'm not going to bother showing you any of the charts or dashboarding tools because the rates for each of these outcomes are typically 0. And I don't think that that's very interesting. We didn't know that when we stood up these data sharing agreements. Okay, we couldn't know about, that these outcomes were rare enough that the volumes that we have, I mean, we're still getting volumes of hundreds of knee and hip replacements, hundreds of breast reconstructions every year. Okay, but fortunately, these adverse outcomes don't happen that often, that we need to do more advanced analytics. We don't risk adjust to them, okay, because I can't risk adjust for one patient. So we're really still focused on getting our physician community used to reviewing this data and working out some of the kinks with data submission. When our surgeons are more comfortable with our ability to source and process this information, we'll go after some in-hospital outcomes that are less rare or start tracking patients longitudinally after they're discharged. So the Outcomes Information Program is something sort of novel that we do and allows us to see how are our surgeons performing even though we don't operate any hospitals. We get some sense of how they perform in hospitals, and it's in a very standardized way. Individual hospitals have efforts to, track physician performance. They investigate acutely, each of those outcomes. If someone dies or has a heart attack after they have surgery, the hospital definitely looks into that, but there's no systematic data collection and no reporting that comes back to us about it. So moving on to 30-day readmissions. We have a separate but somewhat related initiative to track 30-day readmission rates for our hospitalists. As the name implies, this is a medical specialty that works primarily in that setting, but they do not perform any surgeries. When patients are acutely ill or recovering from surgery, these are the practitioners that are checking on them in the hospital.
So I don't understand the x-axis. So that
I'll get there.
50%, so like the provider X?
Oh, yes. Okay, I'm sorry. So I should probably, you can't see it very well. The colors on here are not great. So this is for 24 providers in a particular month in April of 2015. For each of them, the pink series is the volume of discharges. So provider X discharged just under 60 patients in the month of April. Okay, they made the call, said this person's ready to be discharged. We know that they discharged that patient. And the blue bars are the 30-day readmissions rate. So for provider X here, of those,
50%, more than 50% instead of 50%, right?
this is just under 15%.
But this is like half of the discharged patients.
The patient discharge axis is up at the top. So this pink series corresponds.
Pink, like,
Yeah, and so these bars are actually supposed to, the pink is semi-transparent, and you're supposed to be able to see that provider X has the highest volume, and the volume is ranked down to about 15 for provider A, but you really can't tell. But where these bars are blue, these bars are pink, and where they overlap, it should show up as purple, but you can't see that. I'm sorry. Though I will fix that for next time I decide to show this to a bunch of people. It looks fine on the screen. It looks great on my screen. So it's really shameful that it's just not apparent here. But anyways, so for providers with more than some reasonable number of patients that we could get a percentage, we are able to tell if any of those patients came back to the hospital within 30 days and compute that percentage. Okay. That's the gist of it. I'm sure it's working fine, but so thank you for asking.
You said that from provider A to X is ranked in the ascending order of how many.
Yeah. So provider A here, you can't see it very well, but provider A had about 16 discharges. Provider B had 16. You might be able to see just barely the volume goes like this. Okay, but past this point, all of the pink bars are underneath the blue bars. You just can't see it. I try to make visuals that display a lot of information without. Microsoft Excel doesn't allow me to make 2 sets of bars and have it look kind of nice here, so this was trying to get around that, but obviously it's not working here. So,
well, maybe what we see then that the 30-day readmission rate.
yeah, I mean it varies from about 4% for provider S here up to about 23% for provider C. Okay, that's a tremendous amount of variation. Given the number of patients that each one of them had, some of that activity can't possibly be related to chance. Okay, some of these providers, okay, there's a trade-off when you stay in the hospital and you're recovering between the hospital's needs to free up those bed days and their desire to not have you come back because you had some complication. If they discharge you too soon, it greatly increases the probability that you're going to need to come back to the hospital. Okay.
So is there any actions after PAMP rank the physicians or doctors, like any punishment if their readmission rate is too high?
So fortunately, my department, okay, we are primarily charged with standing up reporting. I do some analyses, but say this reporting, this just goes to the director or the head of the hospitalist specialty line every month, and they're able to review that. This is from when I stood up that reporting, and I just sort of used it as a basis for like, hey, I have this. It shouldn't look that much different, but the hospitalists receive this, and they're doctors. They're competitive, okay? There's obviously some people that are doing something that's very right, and there's some people who maybe have some room for improvement, and we let the individual specialties handle that. Yeah. My department, for the most part, we don't take any punitive measures based on the reporting. If someone asks my opinion, I'll give it to them, usually.
So the incentives for this usually are because, for instance, 30-day readmission rates might go into compensation to physicians. So it's just not necessarily that you have punitive, but it's leading them into showing how much they're likely to get reimbursed. Is that correct?
I don't think for the hospitalists it goes into their compensation directly, but this is a standard metric that is reported for hospitals. Okay, you could probably go on the California Department of Public Health website and pull up statistics about the 30-day readmissions rate for any hospital in California. Okay, and they're all graded based on this. And if they're doing a horrible job with it, someone's going to come and investigate it, and they're potentially going to get their license to operate the hospital yanked. Okay, so the hospitals are definitely tracking this. Okay, but they don't give us information about how each physician is performing because they're focused on running the hospital. Okay, but our hospitalists want to know it. Okay, because they want to know how they're performing. And we have contractual agreements with hospitals where they let our doctors work in their hospital. They don't have to do that. Okay? If we can demonstrate that we care enough about this stuff to track our readmissions rate and do something about it, they're going to want to keep working with us, as opposed to some other medical group that also works in the hospital that isn't able to do this kind of reporting, isn't able to provide that benefit for their providers. So basically, if patients aren't ready to be discharged, it's more likely that they'll come back soon. So within 30 days is like a good cutoff point. Okay, that's a standard metric in the industry. And so our hospitalists receive a monthly report with discharge volumes, readmissions rates, and length of stay. So it's great that we can do this, but it's similar to OIP in that PAMP doesn't explicitly receive admit or discharge data when our patients are seen in a hospital that's not part of Sutter Health by our hospitalists even. But we have the billing data for the services that they provide. And so that billing data is in the form of these CPT codes. Initial visits might be a proxy for admit, and there are specific codes for discharges. Our use of the Sutter Health electronic health record also allows for determination of whether any of those patients discharged by a PAMP provider were readmitted anywhere within the Sutter Health system. So sort of on the edges of our coverage area, it's entirely likely that someone might be seen by one of our hospitalists in a hospital that's not part of Sutter, get discharged, and then get readmitted to California Pacific Medical Center in San Francisco. It's part of Sutter Health. PAMP hospitalists don't work there, but I would get to see that admission. So the standard work, or what's supposed to happen, is that a PAMP hospitalist will see a patient and enter a charge, so one of those CPT codes, for each day that the patient's in the hospital, resulting in a string of charges on consecutive days. So we would be able to determine, okay, this person was admitted here, they were discharged here, maybe they came back. This person, maybe in a different hospital, was admitted at this point, discharged, admitted, discharged. So this is a framework that can support determination of multiple stays and in different locations. This is even better than being a single hospital because we get to see it potentially from the patient perspective. If all the charges are there, it's easy to determine what the length of stay is and the time till the next admit. And hospitalists can weigh how soon they're discharging patients against the rate at which they're being readmitted. Unfortunately, things are seldom that easy. The actual situation is subject to incomplete or imperfect data. The hospital stays sometimes don't have a charge for each day that the person's in the hospital. There are holes. People make mistakes in terms of dates. People actually forget to enter the data for the billing for the services that they provided. It's not something that happens all the time, but if you want to do very large scale reporting on this and there's potential for errors, they're going to stack up. Hospital stays, like I said, they don't necessarily have clearly defined admits and discharges. So we had to make a number of decisions that weighed mistakenly combining multiple visits against greatly inflating the 30-day readmissions rate by breaking individual hospital stays into several if there was any break in the consecutive number of charges. When developing this metric, I was lucky that we had all that OIP data. And I found 4,000 patient stays where I could join to the OIP data this hospitalist data based on the discharge dates. And was able to test a number of hypotheses regarding adherence to the standard work and how that would impact the estimated readmissions rates. So this metric that we have, we're able to estimate a 30-day readmissions rate by provider. It's not perfect, but we've been able to demonstrate that it's good enough to differentiate between providers and can be used to support quality improvement efforts. I tend to like problems like this because someone says, you don't have the data. It can't be done. You can't do this. We were able to source maybe some disparate data. We're able to talk to some subject matter experts. We're able to live with the fact that data is messy and we live in an imperfect world. And if you have enough information, you can maybe come to the determination that you actually can do that thing if you're willing to live with a small amount of error. And it's an amount of error that you can quantify, and you could always go back and test it again. Okay, that's enough with the surgeon stuff, at least for now. And I'm going to move on to PAMP's Oracle forecasting program. And I'm also going to see how I'm doing on time. Oh, there's a clock right up there.
That's correct.
It's correct. Okay, good, good. Okay, I see the second hand ticking and everything. So we started working on this in December of 2015, and it aims to improve same-day access for patients in pediatrics departments. Broadly speaking, access is the notion that patients can see a doctor when they need to. Our focus on same-day access intends to address the most urgent needs in the primary care setting. Having adequate access is key to providing good care. Joel here, he was 15 and had been playing football. He started vomiting, was dizzy and lethargic, possibly had heat stroke, maybe something else is going on. His parents were concerned and wanted him to see his pediatrician, but they were all booked up. And Joel had to go to urgent care multiple times. Though this is just one story, I didn't need to go very far to get it. Joel is actually my manager's son. In a recent assessment by the Boston Consulting Group, consumers identified convenience to healthcare services as their top healthcare need. This study found that same-day, weekend, and extended hours appointments were services that patients would be willing to pay for. Access is also a frequent top contributor to patient satisfaction according to standardized national surveys. Okay, the last time you went to a doctor, did you receive a survey afterwards? Anyone? No, okay. Depending on what healthcare environment you're in, you may or may not. But when you do start receiving them, they will have very simple questions, things like, was it easy to get to the appointment? Was it easy to make your appointment? All of these are very simple questions with Likert scale answers, and they're validated test instruments that translate into patient satisfaction. So access is a big thing, and it's one of 6 dimensions of quality of care according to the Institute of Medicine. Despite my anecdote about Joel, PAMP actually consistently ranks quite high in terms of both access and patient satisfaction. Nonetheless, with stories like this, there's clearly room for improvement. During cold and flu season, department managers really struggle with how to maintain access due to uncertain demand for appointments and variable labor supply due to the holidays. You know, think about Christmas or February, okay? It's the time of year when people are like, watch out for the flu, but it's also the time of the year when people want to take time off to visit their relatives or because their kids are on school break or, you know, a variety of other factors. Given PAMP's size, we clearly have a lot of data about same-day appointments, and my department was asked to see what we could do. So beginning in early 2016, we began piloting this report with a handful of pediatrics departments. It's published by email each morning and is based on data collection and modeling on a department and day basis. Starting on that day, so this is the report from Monday. So starting on Monday and going 2 months into the future, you can't see the next couple pages, it contains a forecast for same-day appointments, the number of appointment slots that have been set aside for same-day access only. So departments are able to, in our clinical system, they're able to block an appointment and have it automatically open up for booking on the day when that comes. And also the total number of open appointment slots in their department at any point for that day. So on Monday, even though these were the slots that were earmarked as same-day slots, there were 4 more slots that are available. Well, on Monday, those are all same-day slots. So looking later out into the week, okay, they had, let's see, today, they had 24 same-day slots in this pediatrics department, but as of Monday, they had 36 open slots. They could have anywhere between 36 and 24 as of this morning. Maybe they added some more because we were forecasting 40 same-day appointments. And even as of Friday, they should have expected a deficit of 4. So this balance is always just the difference between the open slots and the forecast, with some color coding on the weekdays. Lets them know very visually about any expected deficit. How does it work? For any department, we want to forecast the demand for same-day appointments among their patients. There's a lot of rules that go into deciding for a department who their patient is. But it's not particularly important. But patients are associated with a department. It's basically where you would say, my doctor works out of this location. So patients in a department making same-day appointments anywhere are represented by the blue circle. They can go to that department, which is the green circle, or other departments, or urgent care, the yellow and gray circles. There are also other patients within the system making same-day appointments, and they too can have them in any number of locations. We assume that the demand for same-day appointments is related to the incidence of communicable disease in the community that each department serves. Okay, people are coming to the doctor, they're asking for same-day appointments primarily because they're sick, and they're sick because they got it from someone that they came in contact with. Occasionally, there are situations like Joel, where someone has an urgent need for an appointment, and it's not because they have a communicable disease. But for the most part, same-day appointments are driven by communicable disease in the community. So to allow for fair comparison between the departments, we express this quantity, this demand, as the number of appointments per 1,000 patients in the department. Okay? That would normalize the disease burden between communities or between departments. And for our reporting, we just translate it back into a count. So these patients making same-day appointments, we think that that's the truest representation of the demand. And patients going to another pediatrics department or urgent care are treated generically as this overflow stream. And those coming into a site from any other department is inflow. So the rate at which patients make same-day appointments is this quantity Y. We'd like to maximize the ability of a department to see their own patients, while recognizing that they're not going to turn away patients from other departments, and there will always be some patients in the overflow stream. Okay? Some people, depending on their need, depending on what the problem is, they're not even going to bother checking to see if their kid's sick or has a need. They're not going to bother checking to see whether their department has an appointment. They're going to go to urgent care. Okay? Maybe there's another clinic site that's closer to mom or dad's work. And they have some sort of other reason why they're going to go somewhere that's not the pediatrics department that they're affiliated with. Based on activity Y through day N, we forecast YN plus 1, where the subscript denotes whole days. It's scaled back by 20% for patients going to the department. Okay, we just assume 20% of the people are going to be in the overflow stream. Stakeholders and subject matter experts support the notion that 80% of the demand is a reasonable target. That's why we picked it. We don't model the decision that patients make in going to their own department or somewhere else, but we could. We also don't perform any modeling of when during the day patients create or have same-day appointments. But this too might help departments manage their schedules better. Both of these are in my future work plan. So I've talked a lot about the concept of this. Here's what some data looks like. Okay, this is the demand for a particular pediatrics department in February of 2016. It typically spikes on Mondays, appears to have cyclical behavior on a weekly basis and is influenced by holidays such as President's Day, which was here on the 15th. Okay, Monday is typically the highest day, except on this Monday was President's Day, and a lot of those people came on Tuesday instead. The clinic was closed, but urgent care is open. So we can have appointments every day of the week because patients can always go to urgent care. It's not their department, but we're concerned about the patients in a department. What is their need? This behavior is generalizable to all pediatrics departments. Within a week, the rate can go up and down by a lot. But it does so with a somewhat typical pattern. Compared to the entire department day distribution, if I showed you all the data, the rate for most departments goes up and down a lot even within a typical week. It looks like noise, okay, but it's actually representative of this structure. Due to the high within-week variability, attempts to chart large quantities of daily data can lead to some really ugly graphics and might cause you to think that there's no long-term variation. This, of course, leads to two very useful alternative hypotheses, okay? You just can't see it, maybe. And if it exists, what does it look like each year? So, aggregating the daily data across all departments by day, week of the year, and by week for each year provides visual confirmation of cyclical long-term variation on an annual basis. This is a very busy chart, so I'm going to stop here and make sure you understand what you're looking at because I get a lot of questions about it sometimes. Okay, so this guy, pediatrics weekly average. This is the gray series right in the middle. This is the weekly average of that rate for same-day appointments for all pediatrics departments from 2013 through March of 2016. Separately, on top of that, with the diamonds and the lines, I've got the weekly averages for each year, coded from hot to cool. So 2013 is the red one, 2014 is the orange one, etc. Okay? On a weekly basis, specialty-wide, it looks more or less the same every year. Okay? We also have the daily average. This is the average for that day of the year. It's crazy. Okay, you can't make any sense out of that. And then all of these diamonds, this big cloud, okay, these are each individual department days. There's 52,000 of them here. They're mostly transparent. Where a bunch of them stack up, you can actually see them. They're color-coded very lightly by year. Okay, you can see, look, this green line is a little lower than the other ones. The bottom of this chart is a little greener. Okay, the top of this chart is a little more red. Okay, but for the most part, the averages are more or less the same. This tells us what that behavior is like in aggregate, but says very little about how well that relationship holds for each department. A variety of analysis methods confirm that this relationship does hold. And so here's that same pediatrics department again with the same day appointment rate for February of 2016, shadowed by the prior week, and the same day of the week plotted for last year and 2 years ago. They stack up pretty nice. At least, considering the value could be anything. So we can get a model of this behavior based on his prior values. And that's what we call autoregressive behavior. I'm not going to spend a whole lot of time talking about box Jenkins, but basically this is a framework to building time series models where it could be autoregressive, which means it's modeled based off of its past history. It can be a moving average, which means it has a memory of some random input, or it can be integrated. And this integration form is just a variable transformation of the autoregressive component. Basically, the signal you have can be a combination of both autoregressive and moving average terms. Jenkins helps you narrow down the possibilities from infinity to some reasonable number of models to test. And through that process, we developed an AR model that makes use of the last several days, the same day of the week, last week, as well as the same day of the week for the prior year and 2 years ago, all in the context of what day of the week it is. And we sourced all available data for pediatrics departments going back to 2013 in estimating the coefficients. So in this manner, the model leverages behavior that's generalizable across multiple years and for all pediatrics departments. Some major weaknesses of this formulation are that it might work better for some departments than others, and it's not designed to support new departments. Okay? You need at least data from 2 years ago to compute this forecast. We could have a model where I fit it not using the older terms, but at least for now we're interested in having inputs about what's typical for that time of the year. Between the features that are in the model and the necessary interactions, it has 56 terms. We've been able to achieve an R-squared of about 0.7. We can explain 70% of that activity and forecast based on that. So you have a sense of what terms in the model. Maybe you'd like to know which ones are important. Here's a ranking of the top 30 features where I selected by absolute value, and with some color coding to remind me that last week this dark green line here is among the most important. You should interpret this knowing that Friday is the intercept. So this term is basically added to everything. Here's the 0 line. So things, this term and above, these are all positive. Thursday and below, these are all negative. Terms for the most recent days play a prominent role. So 1, 2, 3, and 4 days ago. And also, you can see down here below 0, okay, there's a bunch of these terms that basically represent penalties for the weekend days. Seems to make sense to me. This model is also relatively stable. If I cut the last 12 months out of the data set that I used to estimate the full model, refit it with 1 year's less data, and then forecast out to that point, I don't really see any difference in performance. It captures the generalizable behavior and isn't necessarily contingent on, it's not going to go bad. There's not an expiration date on it. This is kind of a big thing when you're forecasting. You want to know whether you can count on useful predictions. No matter how good the model fit is, you need to know whether it's going to give good predictions for data from outside what you use to fit the model. On Mondays, we distribute a weekly report that allows each department to see how well the model performed over the last 2 weeks. Prior to joining PAMP, I spent a year working on behalf of the Transplant Center at Barnes-Jewish Hospital in St. Louis, Missouri. They're a comparatively large center performing transplants for heart, lung, kidney, liver, and pancreas. And they're affiliated with a major research university and medical school. Smaller centers are typically limited to 1 or 2 organ programs and have annual transplant volumes that are considerably lower. Barnes was acutely aware that their performance was gauged against that of all the other transplant centers, and that their licensure and standing in the medical community were dependent on some key metrics. So part of my role there was to provide forecasts for these metrics that would be available to Barnes far in advance of the official government reporting. All right, I'm going to have to skip through some of this, but I will give you a brief overview of transplant in the U.S. as opposed to some nasty urban legends you might have heard. The Organ Procurement and Transplantation Network is a subdivision of the Health Resources and Services Administration, or HRSA, in the Department of Health and Human Services. OPTN is the regulatory body for solid organ transplants in the U.S. They set the standards for how it works and are responsible for oversight and evaluation of 250 transplant centers and 58 organ procurement organizations. Since its inception in 1986, OPTN has been run under contract for HRSA by a nonprofit entity known as the United Network for Organ Sharing, or UNOS. For all intents and purposes, OPTN and UNOS are the same thing. In 1999, UNOS launched UNet, an online database for the collection, storage, analysis, and publication of all data pertaining to activity on the waiting list, organ transplants, and post-transplant follow-up and outcomes. UNet's the backbone of how these entities coordinate transplants on a day-to-day basis, and it's a massive repository for data about every organ donation and transplant event in the United States since 1987. The Scientific Registry of Transplants, or SRTR, is affiliated with the Minneapolis Medical Research Foundation and is operated under contract with HRSA to provide statistic and analytic support to OPTN. A great deal of that support comes in the form of semi-annual reporting that's specific to each transplant center. They produce these program-specific reports. Twice a year, transplant programs get a report card based on data that's available in UNet. One of the most critical aspects of these reports is some scoring of graft failure, or organ rejection, and patient survival. For the remainder of this talk, I'll focus on models for 1 and 3 year survival among transplants for heart, lung, and kidney. We're nearing 2:30. Should I wrap it up? I don't know what the end time for these typically is.
Probably it's okay. How many more minutes do you think?
Maybe 10 more minutes tops.
Yeah, okay. That's good.
So here are some excerpts from the program-specific report for Barnes and their kidney transplant program for the January 2017 SRTR report. SRTR performed some data collection and modeling that allows them to report the observed and expected deaths within 1 year of a kidney transplant. On the left, and the relative hazard of that outcome for transplants performed at Barnes as compared to other transplant centers. For surgeries performed over a 2.5 year period, Barnes had fewer than expected deaths in the first year and is among the safest and largest in the country. UNOS uses these outcomes in periodic reviews of each program, and the reports are required to be given to every patient before they even get on the waiting list. So these numbers are really important to the transplant center. Here's that same sort of hazard ratio plot, but for 3 year survival instead of 1. SRTR quantifies performance on these metrics using a standard statistical technique known as a Cox proportional hazards model. I'm not going to spend a whole lot of time talking about Cox models. If you take a biostatistics course, you'll learn about them. Other than that, you can probably look it up or get a survival analysis textbook. My survival analysis textbook conveniently used heart transplants as the example in describing this technique. Okay? Patients have something that happens to them that puts them in a cohort of people that are at risk for an event. They're followed. There's some things that can go into the model that might be relevant to that outcome. Once the models fit, you can estimate the probability of death by any point during that period of time. It works by defining a hazard function, which just tries to get at the probability of death instantaneously at any point in time. You get some data, estimate these coefficients, can find the probability of death by that point in time by integrating or taking the area under the hazard function. So the 10.76 expected deaths shown here were determined by adding up the probabilities for those 464 transplants. A program knows that it's definitely not doing well when the observed deaths are greater than 50% greater than what's expected. The difference between the observed and the expected is greater than 3, and that difference is statistically significant. If a program experiences substandard performance for 3 reports in a row, they can be sure that UNOS will be sending a team of people to ask them what they've been doing, if they can identify the root cause of the problem and what they're going to do about it. And they have to come up with some very convincing memos and submit those and try and basically improve their performance.
So, but actually, this must show that the actual outcomes are actually better than what you would expect.
They are.
So that's something you should be happy about, people should be happy about?
Oh, they should definitely be happy about that. Okay, but I'll get to why this is a problem. The outcome is not a problem. The reporting is problematic. This is why I was asked to work on this. Okay, there's a specific reporting cadence here. Okay, SRTR publishes the reports for every transplant center in the country every 6 months. It's a big operation. They do it for a different cohort of patients every time. There's always going to be some delay associated with data collection, validation, and the modeling work on their end. When faced with substandard performance, one aspect of this that transplant centers need to consider is that their report might not reflect their current policies and procedures. For the 3-year survival models, this is particularly vexing. Okay, for instance, the performance in the 2017 report, right here, okay, this shows outcomes for transplants that occurred during a 2.5-year window from January 2011 through June of 2013, or 3.5 to 6 years prior. So consider a transplant program that effectively received failing grades for the last 2 reports, shown here as nominal reports B and C. Okay. If report D will contain data for transplants that occurred through December of 2013, and all of those people will have 3 years of follow-up by December 2016, then as of the issuance of report C, there's literally nothing that they can do that will impact the outcomes that are reported in report D. Luckily, the Transplant Center has access to all of the data that they submitted in UNET, but SRTR won't be sending the reports until July. Inspection of the terms and coefficients from prior reporting periods indicates that the models don't actually change that much. So if the Transplant Center is willing to accept this level of error, the estimated deaths for report D, okay, they can be estimated using the model from report C. And the observed deaths are also fixed. All those people had 3 years of follow-up. They can estimate a passing or failing grade well in advance of the program-specific report. Data collection for report E here, this is not closed. Okay? The last people who got transplants in the first half of 2014, they'll continue to accrue data through their 3-year survival time point this spring, right now. Okay? There's a chance that the Transplant Center can do something that will actually impact their outcomes for report E. Your tax dollars get used for some very good things sometimes. Okay? This is all coordinated and evaluated through a federal regulatory agency and not a matter of national security. SRTR will tell you what goes into these models and what the coefficient values are. If you're affiliated with a transplant center, you have access to all the data that was submitted through UNET, and SRTR will tell you how they processed each record. Other eligible entities, like if you were looking to do some data science research, may be able to access de-identified data for those purposes. Each model has a lot of terms in it, okay? And the 3-year models frequently have more terms than the 1-year models. Well, given a longer follow-up period, you're more likely to find a larger number of associations between any number of candidate inputs and the outcome you're looking at. It also makes sense that the riskier transplants have more terms. Here's where this was particularly interesting. Using the labels from the features in the models, I've grouped them into 4 broad categories. Things that can be known about the patient when they're added to the waiting list, have some bearing on the estimates of death, but mostly it's characteristics of the donor and recipient at the time of transplant, and a few terms related to the interactions between the two. These are things as technical as the human leukocyte antigen mismatches, or how well the proteins in your tissues are going to get along, or things as mundane as the height ratio of the donor to the recipient. So for instance, you see the lung model has a lot of recipient and donor terms. Okay, that's because your lungs are an organ that has contact with the outside environment. It's another complicating factor that impacts how well the recipient and donor organs are going to cooperate when the transplant occurs. And also, because of, humans are much longer in one direction than the others, even within what's allowable, cardiothoracic surgeons don't like putting lungs from a really tall person in a short person. There's risk involved in that.
Is that partially to explain why in the previous slide you showed us the lung transplant death rates seem to be higher than the heart, kidney?
I would say for lungs in general, it's incredibly difficult to stave off organ rejection. Again, because they're an organ that has contact with the outside environment. So, yeah, it makes a tremendous difference. Also, it's like you might only need one kidney transplant. If your kidney fails, you can get dialysis. If your lungs fail, there's a very limited amount of interventions that we can take. So probably the high value information here is that none of the information used in the models is related to post-transplant care or clinical status. Okay? Survival models can handle this type of input, but these models don't. This is also tremendously beneficial to the transplant center because the expected probability of death is effectively fixed when that person has the transplant. So I'm going to skip this. There's some detective work that goes on here. Okay, most of the things that go into the model, if you had the data, you'd be able to determine how SRTR would process them. Some of them, you would be able to use various data science techniques to determine, how they process that data. There's no checkbox in the data for heavy alcohol use, but a bunch of questions about the amount and extent. So I already described how we might be able to forecast this report for reporting period D. If none of the follow-up care, there's no data entry into the model that figures into the expected values for any of these future reports. So for report period E, for instance, we can calculate the expected deaths just fine. The observed deaths up to that point in the cohort can be tallied, and this information presented to the transplant program. Effectively, they'll be able to know if and how many additional deaths can be tolerated among patients that were transplanted only in the first 6 months of 2014. All the people that got transplanted between January of 2012 and the end of 2013, they've already experienced 3 years worth of follow-up. There's nothing that goes into that outcome. This type of partial forecasting can be conducted several years in advance with the knowledge that some patients haven't completed the data collection, but they can know immediately, even if that cohort's not closed, they can know the expected number of deaths out of that patient population. Okay, a transplant program that's able to, this is inexact as well, but if they can tell that they're going to have a problem far in advance of the official government reporting, and they're competing against all the other transplant centers based on these standard metrics, they're going to be much better prepared to deal with those kinds of problems than their competition is. That's all I've got for you. Thank you very much for, listening to what I had to describe for you. Hopefully it's been illuminating. If you're working in data science, dealing with large quantities of data, and you need to create models, you'll face these kinds of problems. Fortunately, when you start, most of it will also likely be really easy. They'll say, like, I need to know how many people got this vaccine, and if you know your way around the clinical system or whatever, like, that's easy. You say, give me 2 weeks to work on it, and then you go and you either do it in a couple hours or you fumble through it and get it to them a week later, and they're very happy. And it gives you time to work on the more involved problems. So thank you very much. I hope that this was worth your time. And thank you for having me.
Questions? Yeah, so I think we're going to have another talk coming up at 3, so before that we can take like 1 or 2 questions.
So we want to explain a little bit more about the relationship between PAMP and the hospitals.
Between PAMP and the hospitals? Yes. So when I say we're a medical foundation, basically PAMP has a number of clinics where there will be like a lot of doctors' departments. So it might be family medicine, pediatrics, dermatology, gastroenterology. Maybe there's some x-ray equipment there. But it's not a hospital. It's just a big medical office. And there are specialists that maybe work in hospitals, but we don't own the hospital. And it's also maybe not within Sutter Health. So when you go to the hospital, maybe you're seen by a doctor that works for your healthcare provider. They're not employed by the hospital. The hospital might not actually share that data with your healthcare provider, which makes sort of tracking what happens to people difficult. We have a number of tools, like Epic has a program called Epic Care Everywhere, okay, where if I was sick and I was in the hospital, say I was in one of our partnering hospitals that's not in Sutter Health, say I had a visit there, and then I went back and I was seen by my doctor. They have some tools that if I am in the doctor's office, the doctor can open up my chart, and if the other hospital is running Epic, it will link those records and will allow the doctor to see what happened to me while I was in the hospital. But only within the context of me having that office visit. For the analytic community, I don't get access to any of that data. It doesn't flow into our instance of Epic. Epic's just coordinated a little window between the systems for if the patient is in the doctor's office. And that also causes us a lot of problems because, frequently when we're standing up reporting for stakeholders, like, they have no concept of how this stuff works. They're like, well, I can see it, So it results in having to have a lot of conversations about what what do I have access to and what do I not.
Thank you.
Thank you.